Good morning, everyone, and welcome to Trio Maryland Virtual Transplant Journey 2024. We look forward to a program filled with great information and takeaways, and we want to open the event with a video from Marty Marin, the president and co-founder of Trio Maryland.
Good morning, and welcome to Trio Maryland's third virtual transplant conference. We are so excited that you are joining us today for this educational event. I am Marty Marin, president and co-founder of the Maryland chapter of TRIO, which stands for Transplant Recipients International Organization. I am a liver recipient November 2009 at Johns Hopkins Hospital, and I'm closing in on 15 years or 5,296 days. Yay! After my transplant, I became a volunteer at Johns Hopkins Hospital and at Infinite Legacy, and then started working on establishing a Maryland chapter of TRIO. Our mission is to connect transplant recipients with one another, to provide education on transplant topics, and by offering non-clinical support, we complement the services of our healthcare professionals. During the last 11 years, we have offered over 120 monthly educational meetings. We have hosted 5 in-person conferences and 3 virtual conferences. Transplantation is a journey, and our conference brings you topics and information to help you navigate the next stage of your life. TRIO Maryland is a nonprofit 501c3 organization founded and managed by transplant recipients. We are self-funded, raising money we need to continue our programs. We can offer great events due to the generosity of our members and families. With your financial support, TRIO Maryland will continue to furnish timely and educational information to the transplant community. Let's take a few minutes for some thank yous. I would like to thank the TRIO Maryland Board of Directors and Ashton Conference Planning Professionals, our web hosting company, and TRIO for all that they did to manage the event. Thank you to our partners, Infinite Legacy, Johns Hopkins Hospital, and the University of Maryland Medical Center. I would also like to thank all the presenters for their time and for sharing their expertise on important transplant topics and for sacrificing a Saturday morning. We have wonderful sponsors that are involved in our transplant community. They make our life better, and we wouldn't be here today without their support. Thank you to our sponsors that have supported this year's virtual conference: TRIO National, the National Kidney Foundation of Delaware and Maryland, CareDx, Anatomy Gifts Registry, Peak Relief, and Infinite Legacy. Don't forget to check out our sponsors and their websites for details on their products and services that they offer. Our sponsors make our transplant life better and easier to navigate. Thank you, and we hope today is informative, educational, and helpful as you make your transplant journey.
Thank you, Marty, for that fantastic introduction and kickoff to our 2024 event. We couldn't do it without our sponsors, and we encourage all of you to visit their websites to learn more. TRIO Maryland is excited to be bringing you this conference virtually. A quick reminder that for your individual schedule, you will need to return to the Eventbrite page for the Zoom link for the individual sessions. Each session has its own Zoom link. You can access these links 15 minutes before the start of the session, and they will officially open 5 minutes before the start time so you can get into the room and be ready when we begin. If you need support, please text 301-452-6548 or post in the chat. The first session today is Kidney Transplant 101. Please post your questions in the Q&A tab, and we will share them with the speaker as time allows. Our speaker, Dr. Cristina Mejia, is an assistant professor of medicine at Johns Hopkins University School of Medicine. Her areas of clinical expertise include chronic and acute kidney disease and kidney and pancreatic transplant. She currently serves as the medical director of the Living Kidney Donor Program. I would like to welcome Dr. Mejia.
Michelle, I don't think I'm allowed to share my video.
Oh, let's see what's going on then, people. This is what we do live. Let's see what's happening.
That's okay. You do see the slides though, right?
Yes.
I think it's just my
Let's see if that helps.
Oh.
You got it now?
Yep, absolutely.
Perfect.
Okay, sounds good. So good morning, everybody. And of course, I'd like to thank Trio Maryland for organizing this event. So thank you, Michelle, for the introduction. So let's get it started. And thank you for everybody who logged on a Saturday morning. And hopefully we could make it worth your time. So just a few definitions so that everybody's on the same page, and you'll hear me mention some of these terms along the way. So a transplant candidate is somebody who's being evaluated for a kidney transplant. A transplant recipient is somebody who received a kidney transplant. So sometimes you hear me use this interchangeably, but if you're a person here on the call who has kidney failure, this basically pertains to you. If you are a donor, that's a person who donated a kidney. A deceased donor is somebody who donated a kidney after death. And a living donor is a living person who donated a kidney. When you hear me say allograft or graft, that refers to the transplanted organ, or in this case, of course, a transplanted kidney. And your immune system is a composition of cells and organs in your body that are designed to fight off foreign invasion. It could be in the setting of bacteria when you have an infection, and of course, in the setting of a kidney transplant, it would be the transplanted organ. When you hear me say rejection, it's usually a complication when the immune system fights the transplanted organ. And when we say immunosuppression, it's a state wherein your immune system is weakened. In the setting of a transplant, and it's with the use of medication to prevent rejection. And you hear me refer to it as anti-rejection or being on anti-rejection medications. Okay. So just to dial back a little bit, you'll probably hear your kidney doctors explain to you what the role of the kidneys are. Basically, it removes waste products from the body. It also removes drugs. It also maintains your fluid balance, meaning it gets rid of excess fluid that your body doesn't need. And it releases hormones that can regulate blood pressure. And it can also release hormones or regulate hormones that maintain bone health and red blood cell production. So what do we mean by kidney failure? If you look at the graph on the right, there are certain stages of chronic kidney disease. Usually you start seeing a kidney doctor or nephrologist when you're around like stage 3 kidney disease. When you're, most of the time it's when you're stage 4, when your kidney function is just functioning between like 30 to 15%. And stage 5 kidney disease is when your kidney function is just functioning at less than 15%. Usually when we start labeling you as having end-stage kidney disease, your kidney function is really just functioning between like 5 to 10%, which means that your kidneys are so damaged that it cannot perform its function anymore. And something needs to happen to replace its function. And that's what we generally refer to as kidney replacement therapy. Kidney failure can result from illnesses that directly affect the kidney. You may be familiar with diseases like polycystic kidney disease or some glomerulonephritis or inflammations in the kidney. But other times they can be affected just by other illnesses that affect the kidney as bystanders. For example, people with severe heart disease can have kidney failure as a result of that. So when we talk about kidney replacement therapy, you have several options. You're probably familiar with dialysis, and the types of dialysis are hemodialysis or the blood type of dialysis. And this can be done in the center or at home. And there's also peritoneal dialysis, which is referred to as the belly type of dialysis. And this is also done at home. And of course, the other option is kidney transplant, which is probably why all of you are here today. And the types of kidney transplant is deceased donor kidney transplant, which is, sorry, just give me 1 minute. Apologies for that. Deceased donor kidney transplant occurs when you receive a kidney transplant from somebody who passed away. And a living donor kidney transplant is a kidney transplant that occurs from somebody who donated their kidney. You may also hear us say preemptive kidney transplant. So this refers to receiving a kidney transplant before you even see dialysis. And ideally, your goal is to try to get a preemptive kidney transplant, but this doesn't always happen, and that's okay. And then for other people, they choose the conservative route, wherein they decide that kidney replacement therapy is not for them. And what they usually do is that we focus on symptom management and we just let the natural course of kidney failure take over, which eventually would result to death. So why do we focus on kidney transplant a lot? Because it does carry a lot of benefits. It does treat symptoms and complications of kidney disease. We always emphasize that it's just a treatment modality as well. It's not a cure for kidney failure, but it's just a treatment. But it does lead to longer life expectancy for the recipient of a kidney transplant. It allows for improved quality of life, and it allows you to live without the requirement of dialysis. Of course, it's still a major surgery, so it comes with its own risks. It You can develop complications from surgery. You will be required to be on lifelong anti-rejection medications. And the kidney transplant itself can have complications that are unique to transplant, such as developing rejection, certain types of cancer, diabetes after transplant, infections, and also allograft failure or death. What we tend to emphasize to our candidates is that the benefits of kidney transplant come when you're healthy enough to get a transplant. And that's why you go through a whole process of evaluation to make sure that you'll be able to benefit from a kidney transplant. So just going through your kidney transplant journey, and we'll go through these steps along in the next few minutes. So you start off with getting evaluated when you're diagnosed with kidney failure. So who can be evaluated? Most of the time, it's when your glomerular filtration rate, or GFR, or which in layman's term would be your kidney function, is around close to 20 ml per minute. Or you could just think of it as 20% of function. Usually patients who are, of course, already on dialysis can definitely be evaluated for a kidney transplant. And if you're a diabetic, if you're type 1 diabetic, you may be considered for a kidney pancreas transplant, which would be beyond the scope of this talk. The next step, of course, is to choose a transplant center. Some people decide to list in only one center. Some people decide to list in multiple centers. What I tend to advise my patients is that the data with regards to how well each center is performing is public data. But what's important is that you trust your transplant center, you have a good relation with your transplant center, because getting the transplant is just half of the journey. It's being able to follow up with us afterwards that completes the other half. And making sure you're able to follow at a center which you're comfortable with is always important. And then you go to scheduling your transplant evaluation. And depending on which center you go to, this may be a matter of months. So it doesn't happen quickly. So that's why it's very important for you to try to schedule as early as possible. And then you come to your appointment, which is usually a clinic visit wherein you undergo an evaluation that includes medical, surgical, and psychosocial evaluation. You'll meet a nurse coordinator, and then most of the time you need a transplant nephrologist or a transplant kidney doctor or a transplant surgeon. And then lastly, you'll most likely meet a social worker. And I don't think people realize how important this part is, because identifying social barriers early on, even before you get a transplant, are very important to increase the success of a kidney transplant afterwards. And then the transplant center will require you to do certain lab testing and additional testing afterwards. Most of the time, it's comprised of some blood work. Practically everybody would get some sort of imaging. Usually it's an abdominal CT scan, a chest imaging, either an X-ray or a CT scan. Majority of people will need to undergo cardiovascular evaluation, which involves like an echocardiogram, most of the time a stress test, and just required cancer screening for your age, usually a colonoscopy, pap smear, or a mammogram. And depending on your other illnesses, you may be required to do more testing. And this would depend on what is discovered during your evaluation. So just a few tips is to, before your evaluation even occurs, you want to make sure that you're following up with your doctor for your other medical illnesses. You want to make sure that your diabetes is well controlled. If you do have heart disease, that you've been following with your heart doctor. And you could do this even before you see us during your evaluation. You want to discuss with your primary care doctor if you're up to date with the cancer screening, but because this is a common cause of delay for certain people, meaning they've completed all their transplant workup, but they're having a hard time scheduling a colonoscopy. So as early as like even before you come into us the clinic, it's pretty good for you to take care of these things. You should try to get the recommended vaccines for your age. And the reason for this is you want to have proper prevention for certain infections that will become tricky when your immune system is weak, and certain vaccines don't work as well if they're given after the transplant. And then you want to make sure that if you're on dialysis, is that you're not missing your treatments and you're not missing your follow-ups with your other doctors or medications. You'll often hear us say that we look at your adherence, and this is how well you follow your medical treatments. And the reason for this is that making sure that you're very adherent increases your chances of a successful transplant afterwards. Maintaining your transplant function afterwards requires you to take medications on a daily basis to prevent rejection. And we want to make sure that we're able to address any barriers or any issues that may be leading you to having a hard time with following up um, ahead of time, even before you get a kidney transplant. So when you schedule your evaluation and before your evaluation, a tip I tell my patients is that you always want to try to learn ahead. And probably for most of you, that's why you're joining sessions like this. Before your visit, try to write down your questions. And of course, don't forget to bring your list. It's most of the time you don't realize that your evaluation visit may be the only time you'll see a kidney doctor or a kidney surgeon. It may be years before you see them again, or sometimes you just see them again at the time of your transplant. So it's the best opportunity for you to learn more about kidney transplant, and writing down questions ahead of time always helps. It's good to have somebody come with you as support. You'll receive a lot of information, and it really takes a community to make a transplant successful. So bring somebody to help you out. And usually the person we advise you to bring is somebody who will be helping you out after the transplant, or even your potential donor. Another important tip is you want to be honest with the transplant team. Make sure you disclose your medical and psychosocial concerns. The purpose of evaluation is not to judge you, but to help you make the transplant as successful as possible. So the more we learn beforehand, the better we could address it, and the better help we could give you. And then you want to maintain communication with the transplant team. It's common that sometimes people don't communicate with us, and that can actually lead to their case being closed. And the last thing you want is for your case to be closed just because we haven't heard from you in a while. And then just be a little bit patient with us as well. The purpose of the evaluation at the end of the day is to make the transplant as safe and successful as possible. And many times you really need to undergo a lot of medical testing to make sure that this is the case. And then after you complete your evaluation and after you complete your workup, your case is brought to a transplant committee review meeting, which composed of a multidisciplinary team. The outcome of this committee review would be to determine if you're a candidate or not. And if you are a candidate, you'll either have two statuses. Either you're listed active, meaning you're gaining time and you can already receive deceased donor offers, or you may be listed inactive, meaning you're still gaining time on the wait list, but you cannot receive offers at this time, whether because you still have some tests to complete, or you have current medical conditions or psychosocial issues that would make a transplant at that time unsafe. So usually for some centers, you would hear them say that your case is on hold, but that's okay until you sort out the issues because you're still accruing time. So just a few facts for people on the wait list. Around 100,000 people are waiting for a kidney transplant in the United States as of 2021. Around 26,000 kidney transplants were performed in 2021. So only a quarter of those waiting on the for a kidney transplant actually get transplanted in a year. And for each year, around like 5,000 people die waiting for a kidney transplant. The average wait time for a deceased donor kidney transplant is anywhere between 3 to 6 years. And it really, one of the main factors why there's a huge variation is basically based on the candidate's blood type. Blood type O has usually the longest wait time, and blood type AB has the shortest. And just a few things to keep in mind is you want to make sure you're clear about your listing status. You'll be surprised how many people think that after their evaluation, they're already listed when they're actually not. Or some people thought that after they've completed certain tests, they're already listed when they're actually not. So it's important to communicate with your coordinator and just clarify where you are at in terms of listing. And then, like I mentioned before, you want to make sure that you inform your coordinator about major medical events. For example, while you're in the wait list or while you're waiting for a kidney transplant, you suffer from a major heart attack. These are the things your coordinator needs to know because this would require you to be put inactive temporarily because it's unsafe for you to get a major surgery around that time. So when you're listed already, you are basically waiting for kidney offers. And we have what we call a kidney allocation system, which is a nationwide allocation system that tries to, with the goal of trying to allocate kidneys as equitable as possible. So most of the time, how these kidneys are allocated would be based on matching. So the simple ways of matching would be blood type matching and tissue type matching. Tissue type matching, the way you could think about it is we're trying to match a similar donor to a similar recipient to reduce the risk of rejection. And there are certain factors that contribute to how you get priority in terms of getting a kidney offer. The most common factor, or the simplest factor, is how long a candidate has been on the wait list. Pediatric patients do have priority. Prior living donors who develop kidney failure, this occurs rarely, but it does happen, do get priority for getting allocated a kidney. And certain medical situations, which are called medical urgency, tend to give you priority for a kidney transplant. And usually it's your physician who determines this. The usual scenarios is this is a kidney patient on dialysis who's running out of dialysis access. And then kidneys are allocated based on distance. Kidneys are offered to candidates at the transplant center within 250 nautical miles from the donor hospital. So a few tips while you're waiting for these offers. You are required to do some scheduled labs. So one example of this is tissue typing. There are certain intervals of how frequently you'll need to repeat that. If you've been waiting on the wait list for a few years, your cancer screening may need to be updated. And depending on center and depending on your condition, you may be asked to come back for a reevaluation. What's very important is that you stay on top of these things because sometimes if your testing is not up to date and an offer comes for you, you may not be able to get that offer. So what you need to keep in mind is every time an offer comes for you, somebody from our team reviews your records thoroughly to see if you're still medically appropriate to get an offer at that time. So you want to make sure as well that your coordinator is updated if you do have a change in your phone number or email address or even your physical address. You want to make sure that we're able to reach you if an offer comes along for you. And you want to make sure that your voicemail is set up and you pick up calls from the hospital. Sometimes you receive an offer earlier than what you're expected for various reasons in the allocation system. So you want to make sure you're always ready. And then when you actually get an offer, generally what we say is that you'll receive a lot more information about this at the time of your evaluation, but you should probably worry less about like infection risks like HIV, hepatitis C, and hepatitis B. These are things that we screen on a routine basis in the donors, and after you get a transplant, you also get screened for these. The screening tests are very, very good, and there are treatment options if in the rare case that infections happens. Generally, what we think is that the risks of staying on dialysis and not getting a transplant are more than the potential harms of getting an infection through a transplant. And then just a few things that we commonly get asked about is that, is it good to multi-list or list in multiple centers? There's pros and cons to it, but generally what we say is that if you do want to multi-list, it's probably best to try to look for centers outside the 250 nautical radius, but it's really depending on the person. What we do want to emphasize is that while you're waiting on the wait list, it's really important to still try to look for potential living donors. And the reason for this is that while waiting on the wait list, you may be waiting for 3 to 6 years, but if you do have a living donor, it can expedite the transplant surgery. So just a few things about living kidney donation and living donor kidney transplant. Around 6,000 living donor transplants happened in 2021. And why do we emphasize this a lot is because it allows you to have a longer graft survival. On the average, a kidney coming from a living person can last around like 20 years compared to around like 14 years in a deceased donor. It's easy that we see kidneys from living donors that last 30 years, 40 years even. It also leads to better patient survival. And one of the biggest factors why is that it can be done preemptively. As I mentioned before, it can be done before you're even on dialysis, or it can reduce the time you are at dialysis. And then most of the time, kidneys from living donors have immediate or good function. And then, of course, it frees up a deceased donor for those who are waiting without a living donor. So there are two types of living donor transplants. It can be from a directed donor. This donor has a targeted recipient, or a non-directed donor, wherein this was previously referred to as altruistic donor, or there's just a good Samaritan who comes forward and wants to donate their kidney. So just a few misconceptions, just to clarify these things. Some people think that donors with high blood pressure cannot donate. So we take it at a case-to-case basis. Older patients who may have some mild hypertension are usually now allowed to donate, depending if, of course, if we make sure that they don't have any other medical illnesses that may complicate things. Some people think that only the relatives can donate to certain candidates. And of course, we know that this isn't true. Non-relatives can donate, friends can donate, strangers have donated to strangers. So the more people who can possibly donate to you, the better. And then some people think that the donor needs to donate at the same center as the recipient. Of course, we prefer that just because the logistics of that is a little bit easier. But for example, you're in Maryland and you have a potential donor in the West Coast. Sometimes what happens is that your donor in the West Coast looks for a donor center locally. And then when their workup pans out, their kidneys are just shipped to us. Or sometimes what happens is that if your donor isn't in Maryland, sometimes we can work with them and they start their workup locally. And then they, at some point, they just have to come in for their evaluation and of course at the time of surgery. And then one misconception, of course, is that the donor needs to be the same blood type as the recipient or the candidate. And the reason why this isn't a barrier anymore is because now we have what we call the kidney pair donation program. So when you have a donor and recipient pair that are incompatible, whether it's because of blood type or because of tissue typing, we have the option of entering you into the paired exchange program. So this is usually either handled by the center or by outside organizations like the National Kidney Registry, wherein a donor and recipient pair is entered, and a potential match is and then you wait for a potential match. So what happens in the swap is that, for example, donor one and recipient one are not are an incompatible match or not a good match. Donor two and recipient two are in the same situation. When we enter them into the pair and this pair is found to be compatible, donor one will donate to recipient two, and donor two will donate to recipient one. So there's also another situation where a chain occurs. And this usually happens when a non-directed donor comes forward. And then that starts a chain with the end recipient being somebody waiting on the wait list without a potential donor. So just a few things about the kidney donation surgery, or what we call donor nephrectomy. It rarely results in kidney failure by itself. Usually other things occur or other kidney diseases develop that contribute to kidney failure after kidney donation. For example, a young donor donates when they're in their 30s and then develops insulin dependent diabetes when they're in their 30s or 40s. So that can potentially result in like either advanced chronic kidney disease after kidney donation. And then usually what you need to keep in mind is that donor candidates undergo an extensive medical, surgical, and psychosocial evaluation themselves. So usually for healthy donors, this is probably the most extensive workup they'd ever get in their lives. And the reason for this is the donor team wants to ensure that it's safe, or the risks on the donor is at a minimal, because in reality, a donor doesn't have any medical benefit that comes out of donor surgery. So the surgery itself for the donor is either laparoscopic or robotic. Usually hospitalization is just around like 48 hours, 72 hours at most. And the recovery time is anywhere from like 4 to 6 weeks. It does have some financial burden on certain donors. So there's travel cost, there's cost in terms of lost wages. But if this is a barrier, there are services that help with this. And this is usually presented to the donor at the time of evaluation. And then just a few tips again. Again, as I mentioned before, you want to try to find as many donors as possible. And the reason for this is sometimes we discover things in the donor as we work them up. It's not surprising that we've been able to diagnose things like polycystic kidney in somebody who presents as a donor. Some donors learn that they have hypertension for the first time when we evaluate them for kidney donation, and some even discover that they have a bleeding disorder. So the more donors you have, the more options you have. And then what we also tend to advise candidates is that try not to do your own medical screening. You could leave it up to the to the donor team, because sometimes you feel that these people aren't suitable donors, but they may actually be okay. So just leave it up to us. And then when you're entered into the swap, there's usually like more of a demand for blood type O donors. So for example, your donor is a blood type A and you're a blood type B, you're entered into the paired. You could still look for other donors. And for example, if you find like a donor who has blood type O, you could work with your center to try to see if that donor can be worked up to increase your chances of getting an offer in the paired. And you could still look for potential donors who could potentially donate directly to you, and these donors can still be worked up. And then the most important thing when you're trying to look for donors is you want to share your story. You want to make a list of people to tell your story to, and you should include friends, family. Some people share it in their church groups, school, work groups. Some people post like a flyer in their office bulletin board. Use platforms like social media. Some people create personal websites or go on radio stations. And sometimes it's good for you to find yourself a champion, meaning if you're not comfortable yourself asking people to become donors for you, you could identify somebody in your family or a close friend who could help you share your story. What's very important to understand is that until people know that you need a kidney, they may not come forward. So until you ask, you never know who could come forward for you. And then it's good to use resources that are already available. So for example, the National Kidney Foundation has a program called the Big Ask, Big Give, wherein they educate recipients or candidates on how to ask potential donors. And then a website or apps like the donor app, which allows you to create a story and automatically share this in your social media feeds. So now we move on to the transplant surgery itself. So the timing of it really depends if you're going to get a deceased or a living donor transplant. For a deceased donor transplant, of course, the offers are a little bit unpredictable. So you don't know when you'll get it. But at the time that you get an offer, most of the time, we hope that you can get to a center within 12 to 24 hours of getting the offer. Whenever you get an offer, you need to keep in mind that sometimes you're just the backup recipient, meaning if the target recipient doesn't go ahead, then you're second in line for it, but you still need to be prepared. When you're scheduled for a living donor kidney transplant, usually if it's direct donation to you, it's scheduled, so a date in the future is determined. But when you're entered into the kidney pair donation program, it's a little bit less predictable, and the schedule needs to be acceptable for all the centers involved. And usually it's a few days or a few weeks after a match comes about. And then the transplant surgery itself is either open or robotic. So when it's open, you'll have a tiny incision around the groin area. And then in an uncomplicated case, your hospital stay can be anywhere from like 3 to 7 days. You will receive intravenous or IV anti-rejection medications, which we call on as induction at the time of surgery. So these medications are pretty strong and last in your body for a few months. And then there's always a risk of what we call delayed graft function, which is when you need dialysis until the kidney transplant starts working well. And then while you're still in the hospital, and these are the things that are a pharmacist goes over with you closer to when you're about to go home, you'll be on 2 to 3 maintenance medications to prevent rejection. This depends on centers, but most of the time you'll be on medications like tacrolimus, mycophenolate, and prednisone. Generally, what you should know right now is that these medications are things that you take either lifelong or as long as the allograft is functioning. Each center has their own protocols on which medications they use. And then one important thing for women of childbearing age who are receiving a transplant is the medication called mycophenolate is teratogenic or can cause birth defects. So you need to work closely with your transplant center if at any one point after your transplant you're interested in conceiving. And then after the surgery, you'll be on at least 3 medications to prevent common infections after a transplant. You'll be on this for a few months and then eventually they're discontinued. And then you would anticipate that there's a lot of changes that would occur in your old medications. So sometimes your blood pressure medications may change. Sometimes the need for water pills may change. And some of the medications you're on while you're on dialysis, you may not require anymore. And then what to anticipate after your surgery is that you'll require frequent blood work and urine tests, usually during the first few months after transplant. And then the interval of increases over time. What's important that we look at in these lab tests is that we check your drug levels of certain drugs like tacrolimus. And this is to ensure that you're getting good enough levels of anti-rejection medications to prevent rejection. And then, of course, the other important thing that we look at in the labs is to monitor your transplant function and other complications of it. Usually, we look at your creatinine to see if there's any change. We look at things like protein in your urine to see if there's any change. And we look at things like your hemoglobin, your white count to see if there's any complications associated with either the surgery or the medications you're getting. And then early after transplant, you'll be expected to be seen in clinic for a visit. And then the interval of that also increases over time. And then other things that you need to be aware of is that early after transplant, your blood sugars and your blood pressures may be a little bit labile. Sometimes if you were a diabetic and you weren't on insulin before, you may need insulin. Sometimes you need insulin for a short period of time, and then other medications are used. But these are things that you should expect after a transplant. Sometimes you may need the help of water pills for fluid retention. And then other complications associated with a kidney transplant could be post-surgical, such as having bleeding, hematomas, or a stricture, which is a narrowing of where your urine flows. Infections can be common, and the most common are urinary tract infections. Some people would need a blood transfusion after transplant, and some people deal with electrolyte abnormalities, most commonly elevations in blood potassium levels. And then, of course, different people would experience or have different tolerance to the side effect of medications. For some people, they barely have it. Other people are a little bit more sensitive to it. And then this is center to center dependent. So not all of you may undergo this, but sometimes a stent or like a tube is placed in the ureter where your urine flows and where your transplanted kidney is connected to your bladder. So sometimes a few weeks after your kidney transplant, this needs to be pulled out by the urologist. And then things to expect is that there may be certain restrictions after your transplant. There are certain activities that we advise you to try to avoid, such as like gardening, working with like farm animals. And mostly the concern is increasing infection risks after the transplant. There may be certain dietary restrictions, whether to control your potassium or to limit the risk of infections. So for example, you'll need to avoid raw food. And then certain like things like routine dental work, we sometimes ask you to delay. And then a lot of people do struggle with weight gain after transplant. It really depends on their weight as well prior to the transplant and other factors. And usually the weight gain after transplant is multifactorial. People gain weight just by virtue of the reversal of the inflammation that kidney failure has caused. And then the medications contribute to it, especially prednisone. We always advise you to avoid smoking. And then after your transplant, it's very important that you still follow with your other physicians and your primary care doctors for other illnesses and health maintenance. Kidney transplant, it just solves your kidney failure. It doesn't treat your heart conditions, doesn't treat your diabetes, and also puts you at risk for cancer. So it's pretty important that you maintain your overall health. At the end of the day, half of the patients die with a functioning allograft or a functioning transplant. And the most common causes of death after a transplant are still their usual things like cardiovascular disease, infections, and cancers. It's for those who aren't diabetics, it's very important that you're screened for post-transplant diabetes. Medications like tacrolimus contribute to you developing diabetes after a transplant. It doesn't happen to everybody, but it can be common. And then certain cancers are more common after the transplant, especially skin cancers. So you will be required to see a dermatologist on an annual basis. And then other important things to remember is that each kidney transplant function is different. So one person may have a baseline function after transplant of creatinine of 1, another person may have a creatinine of 2. So everybody will settle at a certain number. It's based on multiple factors from donor factors, recipient factors, and factors that occur at the time of transplant, as well as complications as well. So it's important that when you follow up, you discuss with your transplant kidney doctor what your function is. And then rejection is highest within the first year of transplant, but it can happen at any time. When rejection happens late after transplant, usually that's in the setting of either a recipient is not taking their anti-rejection medications as they're supposed to be, or your anti-rejection medications were reduced for indications like infections or certain cancers. And then one important thing to keep in mind is that early kidney dysfunction or your transplant dysfunction doesn't usually have any symptoms. So that's why lab monitoring is very important, because most of the time we just detect a change in your creatinine or a change in the protein in your urine, and that triggers a workup for things like rejection or other complications. And the one thing that you want to keep in mind is that you want to catch these changes early enough before they even lead to scarring, so that potentially we could still have time to reverse them. And then other reminders is that the original cause of your kidney disease can sometimes come back in the transplanted kidney. So you hear us mention this often in patients with certain types of glomerulonephritis. Common things like diabetic kidney disease can still happen in the transplanted kidney, and new kidney diseases can still develop in the transplant. It's still a transplant, it's still a kidney, and new diseases can occur. And then, like I mentioned earlier, although many will die with a functioning kidney transplant, some may see dialysis or a second transplant in their lifetime. Again, kidney transplant is just therapy, it's not a cure for kidney failure. So that leads you through your transplant journey, starting from the evaluation to the transplant surgery itself, and transplant follow-up. And just, I guess, a few final words is that we always want you to be responsible for your transplant journey. But at the same time, it is a journey and it is a lot. So you also need to be a little bit easy on yourself. It takes time to absorb all the information that we try to provide you with. And even the recovery process can be a lot for some people. And that's expected. And that's why it's very important for you to have people around you to help you. You want to involve your social circle, and of course you want to let the transplant team help you as well. I've had patients who they've never had any major surgery in their lives, and then they thought they would breeze through a kidney transplant surgery quickly, and it was a lot for them, and they became a little bit emotional afterwards, and that's fine. But you need to let people help you, and you need to let the transplant team help you as well. And then, of course, in addition to maintaining physical health, maintaining good mental health is very important. We sometimes underestimate the importance of this, especially with transplant follow-up. It does have an effect on how well you'll be able to take your medications, to do your blood work, and basically just how you'll deal with living with a kidney transplant. And then lastly, it's probably nice for you to, if you have the mental capacity to do this, share your journey with other patients and other potential donors. You can be an inspiration to them, and for all you know, you may be somebody who would be able to help them with their own kidney transplant journey. So just a few additional resources. The National Kidney Foundation website is pretty helpful. The OPTN has a lot of data if you're interested in looking into transplant centers and transplant outcomes. And then the American Society of Transplantation has a living donor toolkit, which can help help potential living donors understand more things about it. And I think I can stop sharing at this time, and I can open the floor for any questions.
Yes, please. Thank you. Thank you so much. I want to go ahead. We do have some questions. We appreciate that fantastic presentation. What our first question was what psychosocial concerns should we be aware of?
So things that usually our social worker tries to ask you, I mean, the more common things are like histories of like drug use, alcohol use. Those aren't like absolute contraindications, but we want to make sure that you're in a state that we could either help you work it out, or have you go through some other forms of supporting you throughout that process. We usually want to make sure you have a good caregiver plan, meaning somebody needs to be able to help you after the transplant. And again, all those reasons, all the reasons why we go through this is not really to judge anybody, but just to help you make the transplant as successful as possible. So we try to see what are the options with regards to that. In terms of a social worker also looks into financial issues. So for example, if traveling to the transplant center is a barrier for you, then the social worker can try to help you explore options on how this could work, and maybe either direct you to proper resources or to try to figure that out ahead of time. The earlier they are figured out or sorted out before your transplant happens, that's better, because you don't want to be stuck in a situation where you get your transplant, and then the reason your transplant fails or the reason you struggle after the transplant is because of things that we could have like addressed beforehand.
Thank you. Next question was, what is the average wait time?
So it really depends on your blood type, but what we advise patients, it's anywhere between like 3 to 6 years. Usually the longest is for blood type O. It's usually around like 5 to 6 years, and there are other factors that contribute to it. It's what we call sensitization, which is going to be discussed with you a little bit more during the time of evaluation. But for example, you're the type of person who's had a kidney transplant in the past, so you have a lot of like antibodies, or you have a limited you have more limited options in terms of the donors that you can receive, so that can make your wait time a little bit longer, but on the average, a good number to think of is around 3 to 6 years.
Great, thank you. Our next question is, how much medication do you typically take after surgery?
So your maintenance medication, so most of the time you're still on usual medications to control like blood pressure, diabetes, if you have other illnesses like thyroid diseases that you're maintained on, so those stay. The medications that you're usually taking while you're on dialysis, like phosphate binders, medications to lower your potassium, sometimes those come off after transplant. And then new medications that come in would be your anti-rejection medications, which would be anywhere from 2 to 3 medications. Half of the centers would probably put you on 3 medications. Half of the centers would probably put you on 2 medications. It really depends on the center's experience. And then for a short period of time after the transplant, you'll be on some medications that prevent infections, common infections, what we call CMV, PCP or PJP, and you'll be on that for a few months, and then afterwards there's stop.
So thank you. The next question is, what are the forever medications, and can any of them be avoided?
So most of the time, I would say your forever medication would be the tacrolimus, or a medication like similar to that, your main anti-rejection medications. For centers who use prednisone, many times you're on that as well. The mycophenolate, most of the time you're on it, but depending if there's indications to take you off of it, like certain infections or skin cancers, sometimes you're off of it. So I would say to prevent rejection, lifelong medications would be at least 2, maybe tacrolimus and either prednisone or your mycophenolate.
Great, thank you. How difficult is it to get transplant with immunogenicity, and what is the success rate?
So it really depends. It's a difficult question to answer because each person has different immunogenicity or an immunogenic profile, and that's why matching occurs. So each, I think the candidates are under the impression that there's just only one major list. But actually what happens is for every donor that comes in, there's a set of patients that can potentially match for that donor. So a certain donor is only offered to a certain set of candidates. And the reason for that is to maximize the immunogenic matching. So success rates nowadays are pretty good, like easily like 1 to 5 year survivals, or like definitely upwards of 90%. And then 1 year survival getting definitely greater than like 95%. And the reason for that is that the anti-rejection medications that you're maintained on, especially like tacrolimus, have really improved outcomes with regards to that.
Thank you. And then just a general, how many hours is the surgery typically?
So, it's a good question for the surgeon. But usually I would say an uncomplicated, it's a few hours. Definitely you're in the I guess I don't feel comfortable saying something from the top of my head because I don't really do this.
Actually, I would recommend Dr. Niederhaus's session. She talks about day in the life of a transplant surgeon. So I
Yeah,
bet
but
she can answer that one.
yeah, but I would say like a few hours. You're definitely in there for a few hours. I would say like 3 hours maybe is a good number to start off with. It could be longer than that for sure.
Then is the BKV common in transplant recipients, and how can I get rid of it? I was told that I need another transplant.
So BK virus, so it's a virus that's pretty much everybody probably has in their urinary system. And then when you get a transplant and when you're put on anti-rejection medications, your immune system is weakened. So that virus pops up. So usually the way it is so common and it happens. And usually the way we try to reduce the occurrence of that is we try to modify your immunosuppression. So that's one complication after the transplant that requires lower anti-rejection medications. But we do see in certain situations that it can lead to failure of the transplant.
Yeah. Then how many times a day would I have to take the anti-rejection medication?
So, so the tacrolimus, there's two formulations of it. Sometimes you take it once a day, sometimes you take it twice a day. The mycophenolate, most of the time you're taking that twice a day, and the prednisone is a once a day medication.
That leads us into the next question. What do you think about the clinical trials for medications to replace tacrolimus?
So that's a very good question. So there are the most common that you'll probably hear is the medication called belatacept, which is like an infusion that you're taking. So the important things to consider about that is it really depends on which on it really depends on a lot of factors, which include what your match is or what your risk of rejections is. So we usually take it on a case-to-case basis. There are a certain group of patients who they could definitely benefit from it, but there are certain patients who probably wouldn't gain the same benefit. So I would say it's something that would be good to take on a case-to-case basis or discuss on a case-to-case basis. And things that also factor in is that what complications you may have had or after the transplant. If you had certain things like rejection, certain infections like CMV, those factor into the decision about that. But
And then,
so far for now, I would say tacrolimus is still the main medication that many centers use.
so then I have one more question. One of our attendees has had some tough days with sleeplessness from the prednisone, believes it's from compromised kidney functions and that it stayed in his system longer. And he's really terrified that if he's on it for life, he won't have a good night's sleep again. Do you have a kind of a response as to use of prednisone?
So so like I mentioned, like it really the immunosuppression regimen really depends on center to center. So for example, at my center we do use prednisone as long as possible, lifelong if possible, but really we weigh the risks and benefits of like the side effects of it. So I would recommend that, but for some cases we've had patients where we've taken them off of it. So I would recommend is you have a discussion with your transplant provider to try to come up with alternatives. And at the end of the day, it's always weighing the risks and benefits. Meaning, if for you, the sleeplessness is something that's really like a priority, and you may feel that that's more important than maybe a minor risk of developing rejection, then at the end of the day, it's a shared decision between you and the transplant center, because what's really important is your quality of life as well, how you want to live your life, and what your goals are as well.
I have a question about they had a liver transplant in 92. They've been taking cyclosporin and will get another anti-rejection drug after will they get another anti-rejection drug after their kidney transplant?
So no, that's a very good question. So cyclosporin has been greatly replaced by tacrolimus, but it it's in the same family of medications. But most of the time, we've placed patients, for example, if they were on cyclosporin before, and they're going to get a kidney transplant, sometimes we shift your cyclosporin to tacrolimus. The tacrolimus would be good enough to protect your liver transplant as well. So a lot of patients who get liver transplant nowadays are on tacrolimus, maybe prednisone, maybe mycophenolate as well. So tacrolimus would most likely be what you'll be on. Except if there's any reason for you not to be on tacrolimus, then sometimes cyclosporin can still be used after a kidney transplant.
And we have a question going back to the trials. And they asked, should we accept clinical trial of the new medicine to replace the tacrolimus, and how do we know?
So the way I understand the question is more like, should the person consider participating in a clinical trial? I think, like, we always encourage patients that if participating in research studies is something that they're interested in, then they should consider it, mostly because it contributes to the larger pool of information, and you never know if you're going to be that one person who will actually make a difference in the future and help us develop like new therapies. So you should definitely, whenever you enroll in a clinical trial, they go over with you the risks and benefits of it. It really is dependent on what clinical trial you're participating in. If you're accepting of the risks, then you should, and if you want to, then you can. But it's a little bit hard to give like a general advice with regards to that.
Great, thank you. And I think that covers all of our questions. Thank you, Dr. Mejia. This is a great presentation, and we appreciate your time this morning. We also encourage you to visit the TRIO Maryland website, triomaryland.org, to learn more about the organization. And we also encourage you to check out our sponsors who are listed on the Eventbrite site. They make this possible every year, and we really appreciate them. So we will see you at the next Zoom. Thank you again, Dr. Mejia.